Good afternoon, everyone. Why is the class empty? Huh? Do you have any lecture? Training? Clinic, okay. Which posting? Psychiatry, okay. Is it at MNA? Okay, they've not come back. Okay. So when should we start? Do we start right away or we should give them some time? Give them some time. How many minutes? How many minutes? 1 minute. 1 minute has already passed now. I think we should start though because we have a whole lot of things to cover. Yeah. We have a whole lot of things to cover. We have a very broad topic, child and adolescent psychiatry. And the second one is impulse control disorders. So child and adolescent psychiatry is actually a very big branch of psychiatry. It's one of the biggest branches of psychiatry. And funny enough, I think some of you are still fall under children, Abby. Is anybody below the age of 18 here? Okay. So basically, in the context of psychiatry or the context of medicine, a child is any individual that is below the age of 18. So we're going to be looking at the psychiatric disorders or mental health issues that affect individuals that are less than 18 years. And it's also important to know that there are subdivisions of childhood. There are subdivisions because now somebody who is a 17-year-old is almost an adult. So you expect that disorders affecting adults are more likely to affect the person. And this is different from what you could have if someone is maybe 6 years. So it's also important that we look at subdivisions of childhood. So anybody that is between the age of 1 to 3 is called what? Does anybody know? Toddler. So toddler, 3 years and below. Then you have from 3 years to 5 years are preschoolers. Then from 6 years to 11 years or some certain years is school age. Then from 10 years to say 12 years is late childhood. From 12 years to 17, adolescent or later childhood. So let's subdivide it again. Of course, you know about neonates. Who are neonates? First what? 28 days. Okay, that's in pediatrics. Okay. But in broader term, anybody that is less than say 4 months, 6 months. Now, infants are less than 1 year. Then toddler between 1 and 3. Then early childhood between 3 and 5 or 6. Middle childhood between 6 and 10 or 11, depending on the classification. Then late childhood between 10 and 12. Then after that you have adolescents. So these subdivisions have peculiarities in terms of mental health issues. So broadly speaking, child and adolescent psychiatry is the branch of psychiatry that deals with assessment, diagnosis, and treatment of mental health condition occurring in children. So that is what it is. And now I think we need to look at the peculiarities of child and adolescent psychiatry. just like I told you, because of differences in age, you could have peculiarities. Now, one is that, children are less interactive. Especially those maybe below the age of 6, they are unable to vocalize their needs appropriately. So what it means is that the practice of child and adolescent psychiatry relies heavily on the input of caregivers, primary caregivers who are the parents, and also secondary caregivers and people surrounding the child. So it's not possible for you to fully assess a child, although depending on the age, just without interacting with the family members. You need to be able to bring in the family members, because usually it's the family members that present the child. The child does not present themselves. It's the family members. So, and again, in the assessment and treatment of childhood psychiatric disorders, you really need the input of the parents, because it's the parents that will continue with whatever treatment that you've instituted. So, and now there's also differences in symptom presentation. Differences in symptom presentation. I know that they must have taught you different kinds of psychiatric conditions, depression, anxiety, bipolar, right? Have they taught you those? Have you been taught depressive disorders and anxiety disorders? Now, there could be some peculiarities in the presentation. All those psychiatric disorders that they taught you people can occur in childhood, especially in late childhood. But you could have variation in presentation. A child that is depressed might not really tell you, I'm too sad, or whatever. The child might just become irritable. You could have irritability or withdrawal. So what it means is that you need to be subtle when you are dealing with children. You shouldn't be straitjacketed. Oh, they told me that in depression you have so and so. No, you need to bring it down to the child's level, to the child's developmental level. So that is it. So there could be variations in presentation. So, and another thing is that there are also considerations in treatment, especially when you are using drug treatment. Are you getting me? Are you getting what we're just introducing child and adolescent psychiatry and the peculiarities. We're here to go into the details, that's the specific conditions. So we're just talking about the peculiarities of child and adolescent psychiatry that you have to be aware of, so that you'll be able to interact meaningfully with a child. So, and we said that we don't jump into pharmacological therapy in children. We don't jump into pharmacological therapy. It's not usually the first thing. Usually what you do is you could start with psychosocial interventions before you now go to pharmacological treatment. Why? Because children, their brains are still developing. I don't know, what were your thoughts about when the brain stops developing? What were your thoughts? What do you know about developmental chronology of the brain? Can somebody help us? Any idea? Okay, when does the brain start developing? At least in utero. Make an attempt now. I want my class to be interactive. Fourth week, yeah, fourth week. And that is why when you have the formation of neural tube, right? So now the brain continues to develop from utero to maybe around maximum. I'm talking about the rapid phase of brain development, maybe to 3 to 4 years or 5 years. Do you understand? But after that, neuronal development continues, especially the prefrontal cortex. Do you know about the prefrontal cortex of the brain? The prefrontal cortex is the seat of intellectual functioning, the seat of cognition, the seat of judgment, what differentiates you from lower animals. So, and that is why adolescents are more likely to make mistakes, two of us. Is that not? Socially, because that part of the brain is about high level cognitive functioning. So it continues to develop until even 21 years. The brain continues to develop until 21 years or even more than that. Because the more you're exposed to experiences, the more you have strengthening of synapses. The more you have sprouting of some dendrites and all that. So the brain continues to develop, although the most rapid phase of brain development from utero to is from utero to say 5 years. But after that, the child continues to develop, especially as the child is being exposed to the environment, is being exposed to learning, is being exposed to social norms. So the child continues to develop. And that is why those that are the age of maybe late childhood, adolescents, at times they make rash decisions, they make mistakes. That's because the prefrontal cortex of the brain is yet to develop. So why am I saying that? The neuronal development is something that continues. So, and at that particular point in time, maybe the time that you're seeing the child, maybe a 6-year-old child, the brain is still developing. The brain is still fragile. There's something I want you to take home. When you have extremes of ages, the brains of people that are the extremes of ages, they are fragile. The brains of, for instance, the elderly, maybe from 70 years, and the brains of children, they are fragile. And that fragility makes them likely to develop extrapyramidal side effects. Have you been taught extrapyramidal side effects in use of antipsychotics? So children are more likely to develop extrapyramidal side effects or any other drug-related effects because of their fragility, as in the fragility of their brains or central nervous system. The same thing that happens in adults, people that are elderly. So before you start a child on a drug that you want to start a child, you really need to weigh the pros and cons, so as not to expose the child to unnecessary side effects. So these are the peculiarities. So we are more likely to use psychosocial interventions, that's combination of psychological treatment and social treatment, than medication treatments. But that doesn't mean that medication treatment is not going to be used. But by the time we start discussing the individual neuropsychiatric conditions, you see that there are really some conditions that can be treated with medications, but you still have to look out for drug-related effects. So these are some of the peculiarities. And again, because of the fact that children are less verbal than the adults, they are more likely to be abused. True or false? Are more likely to be abused. In fact, a parent might present the child to the hospital after abusing the child, and tell you, oh, the child fell from this and that, not knowing that it's the injury that is inflicted. Of this guy is doing his head like this. Do you have any experience you want to share with us? No, I saw your body movement. Don't mind me. So what it means is that you need to create an opportunity to interview the child separately. Yes, it's the parents that will come. My child is this, my child is that, my child is not talking, my child is too playful, my child, they hear word and all that. So you still have to create an opportunity to have an interaction with the child. Because there are certain things that, even before presenting the child to the hospital, say, you, the doctor, asked you, if you say this thing, I will flog you, I will deal with you. So you need to create that rapport. We call it therapeutic alliance. Create a therapeutic alliance so that the child can trust you, so that the child can, volunteer information about what is happening to the child. Because at the end of the day, you still have to make your diagnosis, and you still have to tailor your treatment to the child's need. So there is always a need to have, one-on-one interaction with the child. So these are so how many points have I mentioned? How many points have I mentioned? Who are copying? Who is the note taker? The lady that was staying in the front. She didn't come. So who else is good at note taking? I hope people got my lecture materials. Yes. Okay. So who else can help us? Let's see what people have jotted, because it's not just about listening. We need to be able to pick what we are talking about. So what are the peculiarities of child and adolescent psychiatry so far? What are the points that we've made? One person, you said? Extrapyramidal side effects. So what is the import in treatment? What should it make you cautious of? You shouldn't jump into medication treatment. And even if you're using medication, you have to be wary of the side effects. Do you understand? Because their brains are fragile. That's one thing. Which other peculiarity? Young man. Yes. Okay, so they are not outspoken, and what the import is that you really need to involve the parents in the treatment, and you shouldn't just rely wholly on what the parents are saying. You should create an opportunity to have interaction with the patient so that you'll be able to detect some things. For instance, and again, physical examination is very important. Please note it down. Physical examination is very important in management of childhood neuropsychiatric condition. One is that because of the concern that we raised, a child who is being abused, maybe the time they are bringing the child to you, they will wear the child out so that it will cover everything. So you need to physically examine the child. And again, once you see injuries, multiple injuries, you begin to ask questions. Because why is it important? Children who have problem behaviors, they are more likely to be abused. Are you aware of that? Difficult children, they cry a lot, they have problems with attachment, they are developmentally delayed. They are more likely to be abused. So you have to look at, and now this kind of abuse that are meted out to them make their mental health condition deteriorate, because in most cases parents don't have the skills to be able to teach these children to behave normally. Before you know it, they start beating them, locking them and all that, and those things don't help. So you have to look out for those things, because if the child is in a dysfunctional environment, an environment where the child is being abused, what it means is that that child's condition will continue to deteriorate, and the child will now begin to develop other conditions like depression. A child who is maltreated most times, over time the child might get depressed. The child might develop anxiety disorder, especially when he sees the parents, he would start shaking. The child might even develop conduct disorder. Do you know why? Why children who are abused develop conduct issues? Do you know? Self-defense, self-coping mechanism. Yes, self-defense. They're always beaten, and before you know it, they become violent so that they will be able to defend themselves. And that is why many of the people that today they have antisocial personality disorders. Have they taught you antisocial personality disorder? Psychologists, okay. Conduct disorders trace their family. It's either they come from broken homes where they were not shown love, or maybe children that were born and maybe something happened to their parents and they are adopted away and they are maltreated. So they were never shown love. Why should they show love to other people? So these are some of the things that you need to look at. So how many points, please? I need like 5 points before we progress. Just mention them. Those are the back. That back row. Mention the points that we've discussed about the peculiarities of child and adolescent psychiatry. Can you help us? Yeah. You don't know what? Are you here with us? Where is your mind? You're filling a questionnaire. You're not serious, this man. The other person that is at the back, please, can you help us? Young man, yeah, help us. What can you make out of the points that we've been making here. The peculiarities of child and adolescent psychiatry. Just mention one, and I will let you go. What's your name? I'm talking to you. Yeah, what's your name? Huh? Where is that my Olisa? Where is Olisa? He's not here. Please, can somebody help us? Just mention 2 points, okay? Okay. What else? Just mention points. Anybody can. They are prone to mistakes. Yeah, that's good. Physical examination is very important. Why? That is it. And again, physical examination is also important because many of these disorders have neurodevelopmental origin. That's a result of abnormal development of the central nervous system. So you could see people that have congenital abnormalities among child and adolescent cases, people that have intellectual disability, like Down syndrome. So when you look at the facie, you'll be able to know that something is wrong. Do you understand? Some might have small head, microcephaly. These are people that might go on to develop disruptive behaviors, intellectual disability, and all that. So that's another reason why you have to do physical examination, because many of the disorders of children are associated with impaired neuronal development, which can manifest in other ways. Okay, so what else? Lady on sweater. So what's happening now? Where is our mind? Just mention any peculiarity in child and adolescent. Okay. Any other point? And now, another thing is that in child and adolescent psychiatry, you're more likely to have genetic abnormalities. You're more likely to have genetic abnormalities and neurodevelopmental abnormalities. Why? Because these problems are starting much earlier. You know, many of the psychiatric disorders that we have today, functional psychiatric conditions, they start later. Do you understand? Anytime that you have a psychiatric condition starting early, it means that is either you have more genetic abnormalities or more neurodevelopmental abnormalities. These are the kind of people that when you do maybe CT scan or MRI, you might start seeing some changes in their brains. Maybe their brains are smaller than, in terms of volume, are smaller than they should be, or certain areas that mediate cognition might begin to, might get reduced. So you're more likely to find neurodevelopmental, genetic, and inherited disorders among the children population, and that is why they develop these conditions early. So having said that, now, you know, for you to be able to talk about the abnormality, you need to know the normality. So do we know the developmental milestone of children? I want us to talk about motor developmental milestone, cognitive developmental milestone, social developmental milestone. Then in that motor you have gross motor and fine motor. Have we done pediatrics? Have you done pediatrics? You don't. You're still doing it. So tell me about the motor development of children, gross motor development of children. Yeah, you, the fair lady. It's a discussion. You mustn't know it. No, sit down. Just relax. Sit down. To have, okay, yeah, neck, yeah, holding neck. Start crawling? No. Won't you sit before you crawl? Okay. Sit without support. Sit with support. No, sit with support, sit without support. Then crawling, 7. Then what else? Maybe 8 to 9 months, depending on how fast the baby is. Yeah, start standing with support, standing without support. Do you understand? Walking maybe from 1 year to 18 months or something for late workers. So now people that are going to go on to develop, especially neurodevelopmental disorders like autism, attention deficit hyperactivity, we are going to discuss them. They are likely to have impairment in developmental milestone. Do you understand? So when they tell you, maybe you start taking history, they tell you that the child walked at 2 years. Of course, is in alignment with neurodevelopmental hypothesis of that issue, because it's as a result of impaired maturation of the brain that maybe the motor area has not developed appropriately for the child to be able to walk. So that's gross motor. Then you have fine motor. Do you understand? Being able to use hands very well, hand skills, drawing and all that. So people should go and check those things up. So you talk about developmental milestone, you talk about gross motor development, fine motor development, cognitive development, social development. What about social development? It's important. Social development, social smile. Which one is social smile? Yes. Around what time? Three months. Now, there is indiscriminate smile. There is discriminate smile. Indiscriminate, they smile at anybody. Do you understand? Discriminate develops later, when maybe around 3 months. But indiscriminate, they can smile at, just touch them here, they laugh and all that. That's not really, that one is indiscriminate. But by the age of 3 months, they discriminate, especially the mother. Do you understand? Now, that is also the time, about social anxiety, separation anxiety, and stranger anxiety. Have you heard about those things before? So, in stranger anxiety, it occurs when somebody who is not the primary caregiver of the child wants to hold the child. The child will start crying. Do you understand? That's the one that usually develops first. So it's around 3 months to 6 months, stranger anxiety. Now, you also have the stranger anxiety, you have separation anxiety. Separation anxiety. The child always wants to be close to the mother or any other family member that is a primary caregiver. So if the mother leaves, what do you think will happen? The child will start crying. Then when the mother comes back, the child will stop crying. And it is also at this stage that we have what we call attachment. Have you heard about that term, attachment and bonding? So attachment is the depth of relationship between a child and the primary caregiver, which in most cases is the mother. So whereas the bonding is from the mother to the child, that's the difference. The mother bonds to the child attaches to the mother or any other family member. So now I want you to note this, because this is the origin of many psychiatric conditions later in life. There's something that is called secure attachment and insecure attachment. Please note it down, secure and insecure attachment. So insecure attachment, it has to do with a warm relationship between the child and the primary caregiver, who in most cases is the mother or any other family member. And that warmth is as a result of the love that is shown to the child. Maybe the child cries, the mother gives breast milk, the child is provided for, the child is petted, warm relationship between, not that you can't scold the child, but at the end of the day, the level of warmth that you're giving the child is very important, and is quite sufficient. So, and when that happens, the child grows up to develop this feeling that, the world is a good place, I'm loved, people around me love me. So, and that is why when the child is still developing, when there's separation anxiety, when the mother leaves, because the mother is the primary caregiver, so the child seeks for the mother, the return of the mother. But if there is an insecure attachment, when the child is indifferent, whether the mother is there or not. There are some children like that, especially when the child is being beaten up several times. There are mothers today that abuse children, very tender children. if you see injuries. So what do you think will happen to that child? Insecure attachment, disorganized attachment. The child is not, you can't even pick up the attachment pattern. When the mother leaves, the child is not perturbed. When the child comes back, the child is not perturbed. Or maybe the child is crying continuously. The child cannot be consoled by the mother. That is because there is insecure attachment or disorganized attachment. And this can be the onset of psychiatric conditions, especially emotional conditions later in life. A child that grew up to develop secure attachments, believe that he's loved, believe that he's cared about, that people around him love him, his needs are being met. So the child develops that sense of belonging, that I'm accepted, I'm welcomed. So it gives that child a buffer, emotional buffer later in life. Whereas if that attachment is dysfunctional, they continue to see the world as a place that is hostile, and it affects the way they relate with other people. So that's about attachment. Now let's talk about childhood psychiatric conditions. We've done 30 minutes. Childhood psychiatric conditions. First of all, we'll go into the cluster called neurodevelopmental disorders. Neurodevelopmental disorders, just like the name is, you have impaired neuronal development, impaired development of the structures of the central nervous system, especially the brain, as a result of prenatal, natal, and postnatal insults. Do you understand? These are the things that cause impairment, because remember that these disorders manifest early. So whatever that happened is either the thing happened in utero, prenatally, natally, postnatally, or things surrounding pregnancy and birth. Now, prenatally, some of the conditions, and it's very, very important that when you are clocking the mother of a child who has neurodevelopmental disorders, you need to ask about the prenatal history. Why? Can somebody help us? Young man, why do you take prenatal history? Why do you think is important in neurodevelopmental disorders of childhood? No, I'm talking to you. You want him to bail you? Okay, you should bail him. Why is prenatal history important? Which kind of condition are you particular about? Okay. Diabetes, preeclampsia, those things can compromise fetal maternal circulation. What else? Touches. What's the full meaning of touches? Touches. Toxoplasmosis. What? No. C is what? Cytomegalovirus. C is what? The same thing. Okay. H is what? Hepatitis and HIV. E is what? That's it. Epstein-Barr virus. What else? R is rubella. S is syphilis. So touches infection, very important. And the commonest symptom that you want to ask about is fever and rash. Even flu, influenza, there is a high risk of neurodevelopmental issues occurring in children whose mother had influenza during pregnancy. So all these things, how do they cause problem? They elicit immune response. Remember that at the period of pregnancy, the mother has reduced immunity, true or false? Pregnancy is one of the immunosuppressive conditions. So now the mother is prone to all manner of infections, all manner of conditions. And now when the mother is attacked by any of those things, there is immune response. You know about immune response. Am I speaking grammar? What is immune response? Which kind of immune responses do you have? Humoral, yeah, humoral and what? Cell-mediated. So humoral, where you have production of antibodies, do you understand? To attack those antigens, detected from the viral protein codes and all that. So when that immune response is elicited, at times the immune response can be significant, and it will lead to elaboration of what? Cytokines and chemokines, which will go and attack the young brain. Remember that the brain of the child is still developing. So later in life, when the area of the brain that is supposed to be active in a particular period, when it reaches for that particular brain to be active, it's not going to be active because it has been impaired. The function has been impaired by that immune attack elicited by the maternal infection. So these are the things that now natal causes. Natal causes. What do you think are the natal causes? Things you should ask. When you're taking your history, you need to dwell on the things that happened during pregnancy and delivery. So natal history, which history are you expected to take to talk, to rule in neurodevelopmental disorders? The man on black. Which kind of history do you want to take in natal history? That's birth, issues surrounding birth, that can tell you that, most likely this person has a neurodevelopmental disorder. What things can affect the brain? Prolonged labor. What else? What? Okay, that is what? Fetal asphyxia. What else? Obstructed labor, instrumental delivery. Have you done O&G? You are still doing it. So these are the things that can affect the brain, like prolonged labor, obstructed labor, breach. Have they taught you breach presentation? All those things, abnormal lie, all those things, can cause prolonged labor, and maybe a kind of excessive compression on the fetal skull, which can traumatize the brain. Instrumental delivery. So all these things are the things that you have to ask. Did any of these things happen? Because any of those traumatic experiences can traumatize the brain, and remember that the brain is still fragile at that particular point in time. Now postnatal, what about postnatal? The lady on red. I want everybody to be paying attention so I can point at you. The lady on red sweater. What postnatal factors can affect brain development? You don't need to stand up, just relax. You know it. You know it. You don't like talking in the class? So who can help her? I point to somebody to help you, to bail you. Tell somebody you don't have any friend to bail you. Desire. Okay, who is Desire? Desire, bear her. Who is Desire? Bear her. What postnatal factors can affect brain development? Neonatal what? Neonatal what? Well, infection, neonatal or postnatal infections. What else? Jaundice, neonatal jaundice. And which one is more important? Connectirus. Those bilirubin, when they affect the brain, they cause connectirus. So, which other one? What? That one is natal now. That's fetal asphyxia. What? Malnutrition. Yeah, malnutrition is very important. Malnutrition. What else? Febrile convulsion or febrile illnesses. Febrile convulsion. Jaundice, neonatal jaundice. Shaking baby syndrome. It can happen. You know, it's very common. And the problem with that one is that many people don't even know, cannot recall when it happened. They'll just be throwing the baby. Then some can be doing it. Some can be doing it, you know, to like flow with the baby. While some people can, some mothers who even have mental, you know, mothers can have post delivery. Many people have hormonal imbalance, and that's why you have things like postnatal depression, postnatal psychosis, or postpartum psychosis. Why? Because there is significant hormonal imbalance postnatal. You know, the level of estrogen goes down after delivery. Do you understand? Progesterone goes down. All those hormones, they affect the mood. So the mother can actually behave, can be predisposed to, you know, mental health conditions, which will make the mother to maltreat the newborn. This man, that's shaking baby syndrome. And remember that time, there is still gap between the brain matter and the skull. Do you understand? The skull is there. There is a gap. So when you're shaking the baby, there could be a vibration. The gray matter can hit on the skull, and later on, the problem might start manifesting. So these are the factors that have been seen to occur in children who have neurodevelopmental disorders. They are more likely to have experienced prenatal factors of the mother, natal factors during delivery, and postnatal factors, thereby leading to neuronal impairment in neuronal development. So now let's now go into classic types of neurodevelopmental disorders that are seen in children. Do you have any question? Are we following? Okay. So now the first one that we are going to talk about is ADHD. Have people heard that term, ADHD? What is it? Okay, you've been taught that. You read it up. Okay, so attention deficit hyperactivity disorder is a key neurodevelopmental disorder associated with impairment in attention, hyperactivity, and impulsivity. Just like the name is, attention deficit hyperactivity disorder. You have impairment in attention. The person doesn't pay attention. The person is hyperactive, and the person is also impulsive. So, and what are the symptoms? You could have, just like they said, inattention, attention deficit. The child doesn't appear to pay attention. In the class, the child is distracted. You're talking to the child is playing. He's not paying attention. And because of impairment in attention, it will affect the child's academic performance. Because it's when you pay attention that you'll be able to grab what is being taught. And surprisingly, adults also have attention deficit hyperactivity. Some people have ADHD in this class. So, no, but on a serious note too, attention deficit hyperactivity disorder can progress till or into adulthood. But the symptom domain is more likely to be attention deficit, not hyperactivity. Do you understand? Because, you know, we said there are three domains in ADHD: attention deficit, hyperactivity, and impulsivity. Do you understand? So, and there are some that are predominantly inattentive and predominantly hyperactive. So, and I'm saying that although that this is a disorder of childhood, that in some cases they progress into adulthood and persist. And I'm now saying that the symptom domain that most likely persists into adulthood is inattention, not hyperactive. Is it clear? So inattention means that somebody is talking to you, your mind is not there. Even when you try to focus, your mind is not there. You're laughing. Do you have it? No, but there are so many things that can cause that too. Don't go and start diagnosing yourself. Like I said, Dr. Lisa said, hypoglycemia can cause inattention. Do you understand? or maybe mental fatigue and causing attention. But I'm saying that when you've ruled out all these things and it's a pattern, it has persisted, you can't really focus. You find it difficult to bring your mind to the present, and it keeps on moving. So that's that. And I'm saying that in inattention, because of the fact that they don't pay attention, they are more likely to have problems with, the academics. Their grades are not likely to be good because they don't pay attention. It's not that when they read they don't understand, but they are not attentive. Because for you to be able to understand something and recall it in the exam, you must have been able to pay attention. And you know that children, they are not used to reading. It's that thing that they teach them in the class. So they have problems with academics because they can't pay attention. They lose their things a lot. You give the child maybe 5 exercise books, he comes back with 1. He forgets the bag at times. Why? He's not paying attention. So you're talking to him, he appears distracted. He appears he's in a different world. So those are the things. Then hyperactive is that, just like the name is, they are hyperactive. They are jumping from one point to the other. They're always on the move. They interfere with things. Don't worry, I'm going to give you the notes. I'm going to just pay attention and listen. I'll give you the notes. So they're always on the move. But that doesn't mean that male children tend to be a bit hyperactive. So now, for something to be a disorder, it means that the severity level is quite extreme and is causing significant distress to the person and to the people around. That is what characterizes as a disorder. So that a child is playful and all that, if the distress level is not, if the child is still coping, do you understand, to a large extent, and the level of distress to people around is not too much, do you understand? It's not yet disorder. Now, there's something that is called Gaussian curve. Have people done statistics? So in Gaussian curve is a graph of normal distribution. That normal distribution, it means that most characteristics are going to cluster around the mean. Just like we are now, many people are of maybe moderate, above average intelligence. Do you understand? Although this one is the class is supposed to be is most likely to be skewed in terms of intelligence. What if, okay, let's just say when we go to a general population now, we pick like 100 people. Their intelligence quotient is most likely to be around the mean. Now, a few people would have high intelligence while a few people will have low. Do you understand? So the graph of normal distribution is that a characteristic might not really be a problem, even if it's negative. For instance, somebody can exhibit anger. We know that anger is not a wonderful emotion, but normal people exhibit anger. But when the exhibition of anger is too extreme, that maybe the person is now breaking things, there's a problem. It's a disorder. I don't know whether you people are getting me. So this children restlessness, it falls under normal distribution. We know that many male children are active, but when that hyperactivity is now too extreme, it's too disruptive, the child is not paying attention, scattering things, interfering with things, always jumping up and down, and many of those children, they have injuries because they can't keep quiet. They want to cross the road, before you know it, they are hit down. They are not paying attention. They are too restless. You see that the level of distress is significant. That is when it becomes a disorder. So although there are criteria that we use as clinicians, but just know that when it becomes, they say too much of everything is bad. So just understand it that way. That does not mean that when you go home now, you start diagnosing your nephews and nieces as ADHD. So it must have been significant and is affecting several domains. There is impulsivity. Now, under impulsivity, they blot out answers. They don't wait for their turns. They can't control their impulses. Do you understand? They lack self-control. They blot out answers and all that. So these things are the domains of attention deficit hyperactivity disorder. Now, Let's go to their neurobiology. The neurobiology of attention deficit hyperactivity disorder. See, the knowledge of neuroanatomy or neuroscience is very important in understanding psychiatry, because many of these disorders have been mapped to different areas of the brain. Do you know about the subcortical regions of the brain? Cortical and subcortical. When they say cortical and subcortical, what does it mean? He said? Under the cortex. Okay. So now, prefrontal cortex. Is that? Continue. Okay, they have 3 symptom domains. Attention deficit is the first domain. Hyperactivity domain is one. Then impulsivity. And I said that under inattention, they don't pay attention. They lose their things. They have, the academics is not good because they don't pay attention. When you're calling them, it appears as if their mind is somewhere else. Do you understand? They easily lose their things. Then they go to school, for instance, they come back with a few things because they've lost a lot of things, or they didn't remember to pick up those things. Hyperactive, they are jumping from one place to the other, always on the go, interfering with things, spoiling things in the house. They always want to touch things. Do you understand? They are climbing trees, climbing buildings, and before you know it, they have injuries. So these are some of the symptoms. Then under impulsivity, they are unable to hold their impulses in the class. Before you know it, before you finish asking whether they know it or not, they just blot it out. Do you understand? So they are impulsive. They don't control their temper. They don't wait for their turns. Do you understand? Because of impatience. So these are the symptoms. Now I'm talking about the neurobiology. You have 2 broad classifications of or divisions of the brain. You have the cortical system and subcortical system. Now, cortical system is about the gray area or the gray matter. The cortex of the brain, all those folds, gyra and sulci, is the cortex. Now, the prefrontal cortex is the seat of judgment, insight, planning, self-regulation. Do you understand? You know, people that have ADHD, they don't have self-regulation. They're always on the move. So it's either the prefrontal cortex is not working well, or the subcortical system is working excessively. Now, what are the structures in the subcortical system? You have basal ganglia. You know about basal ganglia? Movements. Do you understand? You have basal ganglia. You have amygdala. Amygdala is about emotion. So now, the circuitry or the neurocircuitry of the central nervous system is such a way that the cortical system controls the subcortical system. Is that clear? The cortical system gives out inhibitory signals or inhibitory impulses to the subcortical system. So now, remember that the cortical system is about, prefrontal cortex, function of prefrontal cortex, self-regulation, judgment, planning, emotional regulation, all those things. They lack it. So there is prefrontal cortical deficit. And the most important neurotransmitter that the neurocortical system or the prefrontal cortical system uses is dopamine. There are other neurotransmitters, but it's the dopamine that helps in. Have they taught you synapses? Yes. Have they taught you synapses? Do you understand? You know that if you get a neuron now, you have the dendrites, you have the cell body, you have the axon, you have the terminal button, then you have the synaptic cleft, then you have another neuron or a gland. So neurotransmitters are the vehicles through which neurons communicate to one another. Do you understand? So now I'm saying that the cortical system, the prefrontal cortical system, they have deficit in dopamine. They use dopamine to communicate to other lower centers. but that dopamine is deficient, and that is why they use methylphenidates for the treatment of ADHD and amphetamines. Have you heard about it before? Okay, so when we get to the pharmacological treatment, it's one of the neurodevelopmental disorders that you have use of drugs. So, and it's because there's excessive firing of the subcortical system, and there is reduced firing of the cortical system. And one of the neurotransmitters that is deficient is dopamine. So that is why we use methylphenidate or amphetamine to increase the levels of dopamine in the cortical system. That is the treatment. So let's just recap. We talked about the symptoms, we talked about the pathophysiology. Now the treatment. The treatment is mainly pharmacological. We also have psychosocial treatments. You can have psychosocial. What have they taught you in psychology? So now we know. How many courses how many lectures have you had in psychology? Huh? So another social treatment is to get the family members involved. Tell them that this child has a disorder and teach them how to manage the child. Teach them to reward the child when the child does something that is acceptable. When the child stays quiet and does well in school and all that. And not to withhold the reward when the child is restless. Something like that. So it's just like behavior modification. But the main thing is drug treatment. So another one is autism spectrum disorder. Have you heard about autism? What is autism? Characteristics of autism. Oh, does not social cues. One. What else? Okay, you're raising your hand. Okay, no eye contact. Yes. Some are hyperactive. If there is a general rule. Neurodevelopmental disorders, they in most cases occur as comorbidities. You can have a child that has ADHD and also autism together. A child that has ADHD and also intellectual disability together. Do you understand? But the core symptoms of autism does not involve but you can have hyperactivity. Then what else? Withdrawal. Okay, they are not interactive. So now is a neurodevelopmental disorder that is associated with problems in communication, social communication, language development, and abnormal repetitive repertoire of behaviors, RRB. Problem in social communication and use of language, abnormal repetitive restrictive behavior. So, for instance, people that have autism, they are involved in they have this repetitiveness. They enjoy solitary plays. Normal children, there's a stage for social, what's it called? Cooperative play, solitary play, social play, and all that. Now, normal children, they tend to interact with other children, play. They want to play with other children, but no. Children that have autism, in most cases, they like playing alone, solitary play, and they have a pattern of, like now, if you give them toys now, they start lining it up. In a particular, they can line toys from here to here, and if you disrupt it, tantrum. You know about tantrum? What is tantrum? Excessive, throwing of tantrum, emotional outbursts. They start crying and all that. So, and they also engage in self-injurious behaviors. At times you see them, they will slapping themselves, pulling out their hair and all that. Self-injurious. At times some of them will be hitting their head on the wall. So that's that. Now, problems with social communication and use of language. Many of them are late talkers, and that is why it's very important that parents know some of these things, because many of these behaviors or many of these disorders, they start imperceptibly. You say, no, it's a late talker, nothing is wrong. But before you know it, you see that it's not what you think as a parent. So it starts with they can't use language. A 2-year-old child or a 3-year-old child cannot make a sentence, a 3-word sentence. They can't use language, they can't understand language. You're talking to them, they don't understand it. They have problem with use of language, receptive use of language, expressive use of language, use of social cues. You can like you do like this, come, do like this. They don't know what it is. Or you squeeze your face, they don't know what it is. Or you smile, they don't know what, and they can't reciprocate. You see a child, you're smiling at a child, you're petting the child is withdrawn. So there's a problem with social interaction and social communication, and abnormal, repetitive, restricted movement, repertoire of movement. So that's basically what it is. Now, generally for neurodevelopmental disorders, just like I told us the other day, in the etiology of psychiatric disorders, that you have interaction between what and what. Have you read the notes? Interaction between what is the pathophysiology of most mental conditions? Nature and nurture interaction. Nature is your genetic makeup, your neurological peculiarities. Whereas nature is the environment. It could be stressors, it could be childhood adversity, it could be loss of loved one, it could be any abuse, it could be anything that acts on that genetic vulnerability to make you break down. So now for most neurodevelopmental disorders, in fact they even run in families. In some cases they run in families. I've seen a family that has up to 2 or 3 kids with autism and ADHD. So, and this is as a result of some abnormal genes, single nucleotide polymorphism. This thing is going to come out in MCQ. Better go and read SMPs, and I explained it and I gave out notes. So abnormal genes, minor differences in the structure of nucleotides, that when they coalesce, they predispose to a particular disorder. So certain studies have found out that there are some genetic abnormalities in these people. Certain nucleotide polymorphisms, changes in the structures of genes that, when you bring their individual effects together, they increase the effect size, or they increase the tendency of having neuropsychiatric conditions. Then again, plus all these things that we mentioned, bed trauma, asphyxia, prenatal infections and all that. So all these things, in fact, the pathophysiology is complex, a whole lot of factors. And some people have pointed out some social factors, like poor stimulation. In fact, certain studies found out that this autism, autism is a very, very common psychiatric disorder now. Many children are autistic now. Some attribute it to lack of parental stimulation and exposure. A situation whereby maybe young parents, they are working class, they leave the child, they just drop the child in school and go. Before you know it, in fact, till night you will see them. They rarely interact with the child. Do you understand? So the child definitely will, and that is why before you make a diagnosis of autism, you need to rule out all these things. A child that is not being stimulated, nobody is talking to the child. How do you want the child to learn? Do you understand? So these are some of the factors, social factors. Poor stimulation might make some of these children not gain language ability. So now some have also implicated food. There's an area of psychiatry that is called nutritional psychiatry. These days people eat all manner of food, and you give your child anything, biscuits, mineral, all those highly processed carbohydrates. They've been shown to be associated with neuroinflammation. As a matter of fact, one of the dietary modifications for people that have autism and ADHD is dietary modification. Is really gaining traction, in that area. That people who have autism or ADHD, that when you start to remove all this highly processed food, that some of them tend to recover to an extent. So there are so many factors, that play a complex role in the pathophysiology. So that's autism. So what? Okay. Yes, there's autism spectrum disorder. Now, in that autism spectrum disorder, there's what I call autistic disorder. According to the old classification, in psychiatry, most of these classification systems, they are evolving. So in ICD, you have ICD level 9, you have ICD 10 previously, you have DSM 4, you have DSM 5. So in the previous classification system, you had like 4 subtypes of autism. You have autistic disorder. You have childhood disintegrative disorder. Let me just, since you asked it, let me just answer it. But just know what autism is. It may not, is when you want to specialize in psychiatry that you now do all those ones. So you have childhood disintegrative disorder. You have Asperger syndrome and Rett syndrome. These are the spectrum. Rett syndrome, childhood disintegrative disorder, Asperger syndrome. Now, there's something about Asperger syndrome, and it's very, very important in management of neurodevelopmental disorders. Now, many children that have neurodevelopmental disorders, they have areas of strength, and that is why in the management we do what we call SWOT analysis. Have you heard about SWOT analysis? We find out the strengths of the child in the midst of the weaknesses. Strength of the child, that's S is strength of the child, W is weakness. The weakness is all those abnormalities that is impairing the child's functioning. Now, with SWOT, you have O, opportunities. So in the midst of threats and strengths, what are the opportunities of the child? Then T is threats. That's S is strengths, W is weakness, O is opportunity, T is threats. Now, talking about the spectrum, now there is a spectrum of Asperger syndrome. Now, these people, they don't have all those severe abnormal behaviors, like, beating themselves, slapping themselves, rocking movements and all that. They don't have those things. They might also have mild language problems, but they have areas of strength. In fact, some of them will call them, have you heard about the term idiotic servant? Idiotic servant or idiot servant. What is it? Very, very, like some of these children that have rote memory. I've seen children that can recite the whole chapter of the Bible. Do you understand? Or have bizarre mathematical skills. They can do mathematical computation. Just tell them 525 plus 590. Bam! Do you understand? You're laughing. No, these are, some of them are said to have. Do you know that there is, somebody is saying that Elon Musk was autistic. Have you heard about it before? Yes, they said he was autistic. So now, that spectrum now is most likely Asperger, assuming it's true. It's most likely Asperger, where they have areas of strength that they outshine, that they are particularly good, the way they think. Do you understand? So now, if a child has autism and you try to discover an area of strength, you're going to use it, because now a child who has autism might also have intellectual disability. The child might not end up becoming a professor, but he has a particular skill. Maybe he knows how to use. Is that? He can draw. Some people they are good in music. Autistic children are also good in music. They play complex instruments. So now, if you're able to identify that, you use that in treatment. So you try to downplay this didactic education or whatever. Some people will say, who education help? So you see that if you concentrate that energy that you would have concentrated in training the child, all this secondary and all that, you tailor the teaching to that area, the child would. And of course, once they are doing those things, these children that have these disorders, they know they are different. Somehow they know that they are different. So, but when you harness that strength that they have. Before you know it, start having positive emotion. They have a sense of belonging. They feel that, oh, I can do this thing, other people cannot do it. So it's used therapeutically. So you try to find out the strengths of the child, the weaknesses. You work on the weaknesses by therapy, use of drugs, or behavior modifications. Then opportunities. What are the opportunities that the child has in spite of all these threats and these limitations? And you also try to minimize the threats. Now the threats could be maybe bullying in school. For instance, a child who is autistic, a child who has ADHD might be bullied. So you identify that, you get involved with teachers, so that they will pay special attention to the child. Or if there are some schools that are kind of special schools, children of special needs and all that, where you tell them whatever their strength is and teach them more. So this is the basic way of managing neurodevelopmental disorders. So in the midst of all those limitations, they could still have some strengths, and you capitalize on those strengths, so that at the end of the day they have a sense of belonging. And it will also reduce negative emotion, because they have the knowledge that these things are limitations, and before you know it, they start getting depressed, they start getting anxious, they don't want to go to school because they know that they will be taunted. But when you discover that, you harness that, and so that's that. Any other question? Okay, so another one is intellectual disability, or what they used to call mental retardation. Mental retardation. So mental retardation, no, let's not use mental, because they said that mental retardation is what? Offensive. What? Yeah. And it's stigmatizing. We call it stigmatizing, so we don't use it. So depending on the diagnostic criteria they're using, some call it intellectual disability, some call it learning disability. So it's simply, when an individual, a child's intellectual capacity or functioning and also adaptive functioning is not up to the age appropriate level. The child's intellectual functioning or cognitive ability or language skills or adaptive functioning. Adaptive functioning is the child's ability to take care of themselves, take care of basic activities of daily living, wash their clothes, interact well, and all that. When these skills, cognitive skills and adaptive skills, are not up to age appropriate limits. You know why you say age appropriate? A 5-year-old child, can that child be able to tell you maybe the answer of 500 minus 200? Okay, no, maybe 4-year-old. Even if he gets it, you're squeezing your face. Do you have a 4-year-old that can do that? No, some can do that too. So what I'm saying is, age appropriate is that as the child is developing, the cognitive ability is developing, the language ability is developing, the adaptive skills are developing. So you have to be able, and that is why IQ is what? What's the mathematical formula for IQ? Mental age over chronological age. Mental age. So there is something that is called mental age. There are some children, maybe a 10-year-old child, the way the child is talking, like maybe 15-year-old. That's what? Is that what? Okay, so that's mental age, then chronological age. So that's the simplest way. But there is another way of rating it. They use a Wechsler intelligence scale. Now let's grade mental retardation or intellectual disability. You have any IQ that is less than 70 is intellectual disability. IQ less than 70. So, and now under that intellectual disability or learning disability, you have gradations. You have profound mental retardation, moderate mental severe mental retardation, moderate mental retardation, mild mental retardation. Then you also have borderline intellectual functioning. Borderline intellectual function is between 70 and 80. Borderline. You won't say that the person is. No. It's not under mental retardation. It's just borderline. That means it's remaining small for the person too. Why are people laughing? So, no, of course, everybody that is studying medicine is above 100 now. Who is not? So, now, mild is between 50 and 70. Mild mental retardation. And these people, they are educable. They are educable. People with mild mental retardation are educable. They can attend maybe they can struggle to attend secondary education. Do you understand? But they end up not doing well if they progress. Now, moderate mental retardation is from 35 to 49. Moderate mental retardation. Those ones are trainable. You train them in skills. They are not educable. But people that have mild mental retardation, they are educable and also trainable. Whereas moderates, they are trainable and not educable. Do you understand? So it is good that you grade it so that you don't waste your time. Maybe somebody who has moderate or severe, and they are telling you, I want to write jam, I want to be a graduate. We've seen that happen. The parents will be like, Iga, you are the only one that has not got Iga Agadatakman University. Something like that. I hope all of you are Igbos. All of you Igbos. Sorry, please. So who is not Igbo here? Who is not Igbo? Where are you from? Benue? Oshun, okay. It's all right. No, we will tell you what we are saying. So, now, from 20 to 34. 20 to 34 is severe mental retardation. Severe mental retardation. Those ones, they need help in their day-to-day. Why are you laughing? Why is it funny? They need help in their day-to-day activity, like taking care of themselves, activities of daily living. They need some help, but with support, they can catch up. Now, the last group are profound mental retardation. Profound, IQ less than 20. Profound. So those people, in most cases, they have other neurological conditions. These are people that have cerebral palsy. Have you seen people that have cerebral palsy? They have some motor problems. They weigh on themselves, pull on themselves. So those ones, they require significant help in activities of daily living. Significant. They can't help themselves, actually. They cannot help themselves, actually. So that's the gradation. Now, of course, just like other characteristics, many people fall within, say, 80 to less than 120, or maybe 80 to 115. That's normal population. Do you understand? Now, for people who are extremely intelligent, it's from maybe 120 up.
Extremely like how?
I don't know. It's by rating now. There's a scale. There's a way that intelligence is rated. So, and now, but this one is more of academic. There are domains of intelligence. So it's not only book. Yes. You have emotional intelligence. Yeah. You have social intelligence. Do you understand? All of them are intelligence. So, and again, for you to succeed in life, by the time you finish this medical school, no matter the number of distinctions, for you to succeed, you must have emotional intelligence and social intelligence for you to be a real businessman. Or else you quote all the distance, but nothing to show for it. So don't neglect that one. Though. All these people that are in on the shaman markets making millions, see how serviceable they are and all that. They have emotional and social intelligence. So that's that. So for people, so that's intellectual disability. Not being able to measure up to age-appropriate cognitive and adaptive skills. So that's that. So, and I said that for people that have neurodevelopmental disorders, most of these things, they occur together. Somebody who has severe autism may have co-occurring intellectual disability, something like that. No, not most of them. We just said some because of this the question that this guy asked. The Asperger type, Asperger syndrome. If you see people who are autistic, you pity them. Do you understand? So it's not something you wish. It's most of them are intelligent. Oh, you want to? So it's only a few of them. It's only a few of them that have those areas of strength. To a large extent, is a highly disabling mental condition, and is the burden on the parents is quite much. It's quite significant because something like you have a child and all that. Before you know it, your child is not coping up, and maybe people visit you, don't want to. That's what some of them do. They go and hide the child because they feel that the child will bring embarrassment. You're laughing. No, but that's what happens. That's what happens. So that's that. Now let's go to depressive disorders. So just like you have in adults psychiatry, you also have depressive disorders in children. But I told you that the peculiarity is that children are more likely to exhibit some other, psychopathologies like irritability and withdrawal. So then you also have eating disorders. Have you heard about eating disorders? This one affects women more. Anorexia nervosa, bulimia nervosa. Have you heard about them? What is anorexia nervosa? Because of shape. This guy. So in anorexia nervosa, there is an impairment in body image. Your body image is not realistic. Whereas you're thin, you're saying that you're fat. And because of that, you're restricting energy. You're restricting your body of food because of the fear of getting fat. Do you understand? So, and they do all manner of things. Some they engage in vigorous exercise to lose weight. Some they stab themselves. Some they purge themselves. Some vomit. Tea, slim tea. So there's impairment of body image. And again, their BMI is always low. Less than 18. That's 18 watts kilogram per meter square. So less than, and now they are likely to have a lot of electrolyte imbalances. Do you know why? Because they're energy deficient, and some of them induce vomiting and diarrhea. Do you understand? So you might find things like alkalosis. Everything is hypo. Hypomagnesemia, hypokalemia, hyponatremia, hypo. Everything is hypo because they are losing electrolytes, they are losing micronutrients, they are losing vitamins. So now, what about bulimia nervosa? First of all, they exhibit excessive eating, overindulgence in food. So differentiate it from anorexia nervosa. Anorexia nervosa, they are restricting. They are not taking food enough, and they can even induce vomiting. But in somebody who has bulimia, the person's weight may be okay. He binges, eats a lot. Then later on, he starts having negative emotion that, I'm eating too much. And the person will now start inducing vomiting, purging, and all that. So, but the electrolyte imbalances that you find in anorexia nervosa is much more than the one you find in bulimia nervosa. So, these are some of the distance. Now, you also have conduct issues, conduct disorders. Conduct disorders are also part of disorders that you find in childhood. One is oppositional defiant disorder. Oppositional defiant disorder. Then the other one is conduct disorder. Now, oppositional defiant disorder is characterized by the individual being always irritable, They are usually very irritable. They are argumentative. They argue with their parents. They argue with their superiors. They are vindictive. You know what vindictiveness is? What's vindictiveness? Retaliates. Do you understand? And at times they cause trouble unnecessarily. They look for people's trouble. But the difference between oppositional defiant disorder and conduct disorder is that conduct disorder is the extreme form of disruptive behavior. So in conduct disorder, there is aggression, severe aggression to people around and even to animals. You know why they use animals? You know, it's Oyibo that designed this diagnostic criteria for us. And to them, animals are important, all these pets. So aggression. So if you go to the diagnostic criteria, you see aggression to people and to animals. Non-conformity with rules. They don't conform with rules. They always break down rules. They lie a lot and they are manipulative. They lie, they cheat, and they manipulate others. And they don't have remorse. No remorse. Do you understand? So that's conduct disorder. Aggression to humans and animals. Non-conformity with rules, always breaking down rules. They do what again? They lie a lot. They manipulate people. They cheat. They cheat women. Who said that one? I didn't say that one. Okay? You know, I told you the peculiarities that the people that design this diagnostic criteria, they are Westerners. Do we talk about animals here? We don't have pets. Many people don't have pets. It won't be, it's not only one. It's not only one symptom now. You don't use one symptom. So you usually have groups of symptoms. But these are the characteristics. So, and when this thing has become a pattern, the person continues to do all these things. That's conduct disorder. So oppositional defiant disorder, the oppositional defiant disorder occurs mainly in women, young girls, while conduct disorder occurs mainly in men. It's understandable now. Men are more likely to be violent and fight and all that. So that's that. Is that how? Even biologically, testosterone is an aggressive hormone. Who said that testosterone? You got it right. Testosterone has to do with more aggression. Just like lower animals now, they always protect, they fight and all this thing. Is it conduct disorder? And all these things are disorders of childhood. But now, if they continue till 18 years, before you can make a diagnosis of personality disorder, the person must have reached 18 years. All these words are just straight. But when they continue into 18 years, you now make a diagnosis of antisocial personality disorder. Have you heard about antisocial? Somebody is antisocial, all these criminals and all that. Many of them had conduct disorder while they were adolescents. Do you understand? So there is tendency for the thing to continue into adulthood. And now there is a comorbidity, high level of comorbidity between conduct disorders and substance use. Yeah. Conduct disorders, they like experiment, all this, because they don't conform to rules now. That thing that you say that they don't want, that they shouldn't do, that's what they want to do. They seem to get thrill from committing crime. And all these things, they go hand in hand. They use substances to enable them to even commit more crimes. Like all these criminals, before they go for the operation, what do you think? They drug themselves so that they become more hardened. Even Nigerian criminals. Well, I wouldn't know, but you should know. Intuitively, you should know. You should know. So, I think we should go to impulse control. Let me see if there are so many other disorders of childhood. Okay, now you also have there's an important one that we've not talked about: enuresis and encoparesis. Enuresis and encoparesis. Do you know what enuresis is? What's enuresis? Bedwetting. So it is expected that a child, Oga, what are you doing? What did I say last? Mbamba, before I said it is expected that a child. And encoparesis. So what are you doing with your phone now? Okay. So enuresis and encoparesis. Now, it's expected that a child should have attained some level of urinary continence at the age of 5 to 6. Do you understand? Most children, at least up to 80%, would have achieved urinary continence, especially nocturnal urinary continence. So now for, is that 5 to 6 years? That's the range. Do you understand? It's expected that, you know, we're talking about normality again, the majority. It doesn't mean that you can't find maybe an 8-year-old or 9-year-old that has this thing, bedwetting. Now, for encoparesis is passage of, indiscriminate passage of stool. Do you understand? So, enuresis is passage of urine, wetting of the child's clothing or bedding, whether it is voluntary or involuntary. That's the definition. So the same thing with the encoparesis is expected that a child will have attained fecal continence at the age of 2 to 3 years. Do you understand? So you make a diagnosis of encoparesis from maybe 4 to 5 years, and diagnosis of enuresis maybe from 7 to 8 years. It's a range. So these conditions, they are associated with a significant level of distress to the individual and to people around. For instance, if a child is in boarding school, a female child is in boarding school, what do you think will happen? And the female child is having an enuresis. Bully, you know, what? Taunt her and all that. So it's associated with significant level of emotional difficulty. Many of them, when you screen them, you have some depressive symptoms, anxiety symptoms, because of the fact that, you know, what is happening to them is embarrassing. So, but there are some modifications, some behavioral modifications and therapies that are applied. There's something that we call enuresis alarm. Enuresis alarm. So, there is a way they do it. They attach a sensor, a water sensitive sensor in the child's pajamas, so that when the child is, you know, is at night, when the child is urinating, once urine touches that sensor, it buzzes, and the child will now have to wake up and hold, you know, the bladder and goes and now urinates. Do you understand? So that's enuresis alarm. That's the commonest behavioral therapy for that. Child wears a water sensitive sensor, you know, attached to the pajamas. If the child is about to urinate at night, that's enuresis about to happen. Once the urine touches the sensor, it buzzes, you know, it becomes discordant. The child now has to wake up, and so over time the child, you know, now learns to wake up intermittently to urinate. Now, but that one, in most cases, it doesn't. It's not as if it doesn't work, but the result is neither here nor there. At times it might fail. So what they use is desmopressin. What is desmopressin? What is desmopressin? What is the work of desmopressin? Any distinction in pharmacology? Who? Okay, so what's the mechanism of desmopressin? Okay. No, sit down. Dilate blood vessels. Vasopressin. Okay. No, I'm talking about desmopressin. Desmopressin. So what's desmopressin? Now, vasopressin or ADH, is that not? Antidiuretic hormone is a hormone of the posterior pituitary gland, which is released when there is what? Hyperosmolality or hypovolemia. This physiology now. When there is hyperosmolality or osmolarity, anyone, so is released and it inserts what we call aquaporin channels. Have you heard about aquaporin channels? V2 channels at the collecting ducts, so that you have reabsorption of water. Do you understand? So now this desmopressin is a vasopressin analog. It does the same thing that vasopressin does. Do you understand? So once you give it, it acts on the collecting ducts or tubule, inserting aquaporin channels and reabsorbing water, so that the urinary volume will reduce but effectively, and the child will not have to wet the bed. So that's the pharmacological treatment for enuresis. Is that clear? So we have 30 minutes to go. Let's rush to encopresis. So encopresis, what you do is mainly psychological, mainly psychosocial treatment, toilet training. Do you understand? Token economy, you reward the child. If the child, because at times some of these things can be as a result of some children that exhibit a kind of disruptive behavior. Maybe they want to punish the caregivers. Just go and poo anyhow. It can be a behavioral disorder. So you do behavioral modification. There's something that we call operant conditioning. Have you heard about operant conditioning? Reward and punishment. You reward good behavior and you punish negative behavior. But you don't punish. In psychology, we don't encourage positive punishment like flogging the child. You can withdraw the child's benefits, or you tell the child, any day if you stop pooing anyhow, I will reward you. I'll give you biscuits. Any day you say you want to poo and you indicate and you go to the toilet, I'll reward you. That's token economy or positive reinforcement. By the time they teach you some psychological concept, they will throw more light on it. So that one, there's no drug for that. It's mainly psychosocial intervention. Any other question before we go to impulse control? Okay. So impulse control. That kind of emotion, but this one is a restricted kind of disorder. What the problem is, lack of explosive emotions, inability to control your emotional instincts, making you to have an exaggerated response. Probably you shout, yell, and destroy things, and after some time the thing clears. Then after some time it happens again. So intermittent explosive disorder. You have a question? Okay, now there's also another disorder that has that borderline personality disorder. Have you heard about borderline personality disorder? It happens in women mainly. Borderline mood swings. You have mood swings. You have exaggerated emotional response. You have chaotic relationships. This time this person is my all and all. The other time this person is the worst person. You understand? They have sense of feelings of emptiness, and they are even suicidal. Do you understand? So this is borderline personality disorder. Do you understand? So it's a different kind of disorder. So they can exhibit that kind of emotion, but for borderline you have other issues, other symptoms. But for this one, it's just that emotional dysregulation. And it's intermittent. So intermittent explosive disorder. So the impulse is so strong that they cannot control it, and they have to let it out without control, like emotional discontrol. So that's that. Okay, sit down. This is supposed to be like a seminar. Sit down, ask your question. When the person is feeling depressed, is it like spending spree, excessive buying? Of course, now it can be a dysfunctional coping mechanism. Dysfunctional means unhelpful coping. You have low mood, instead of you to tackle what the problem is. Maybe somebody annoyed you, you go and start buying things, or maybe some people will go and start getting involved in indiscriminate sexual activity because they were hot. Do you understand? So it's dysfunctional coping. Do you understand? It's an abnormal way of coping with stress. People have ways of coping with stress. Some can be helpful, some can be unhelpful. So when you go on spending spree because you're sad, you have depression and you still have dysfunctional coping. Do you understand? And if you're what? If your money finish, you have more depression. You have more depression. So these are that pyromania, kleptomania, intermittent explosive disorder. So these are some of them. Addictive disorder, because everything about the person revolves around that gambling. The academics will suffer, the family life will suffer, just like substance addiction. You even have sexual addiction, you have internet addiction. Overindulgence in sexual activity is also a problem. Remember that we said that behavior is a continuum. Anything that is extreme positive is a disorder, because it's not causing a distress. It's causing distress to you and to people. Because now, if you indulge in, for instance, excessive sexual activity, others are attending lectures. You're doing other things. No, seriously, it has affected your functioning. The same thing with gambling, the same thing with substance use. It's either you're involved in substance use or you're recovering from the effect of substance use. So, but now, pathological gambling is classified as addictive behaviors, I think in ICD-11. So, but under DSM-5 is under impulse control disorder. But you don't need to bother yourself about the classification. Just know the disorders and what they're about. Yeah.
There are people that are pathological gamblers that are not in any way indulgent in substance abuse or recovering from.
Everybody. So for these people that have addiction issues, they have specific addictions. Some may have multiple. Some might have addiction to substance. Some might have internet addiction. You know, there's internet addiction now. Some might have sex addiction. So it mustn't be all. But at times there can still be multiple addictions. Okay.
I want to ask you, do you think can a man have addiction to sex to his wife? Like, is that one also an addiction?
Too much of everything is bad. If involvement in sex, when you're supposed to go to work, you're doing honeymoon. You understand? To the point that you don't even have money, maybe you start borrowing, or they're sacking you in your workplace. It's a disorder now. There's time for everything. Once you engage in a particular thing and is now affecting other important areas of your life, it's a disorder. Okay. Last question,
Everybody has some level of mental.
Yes, so I agree with you. Even personality disorders. You know about personality? You know we don't behave alike. Do we behave alike? Everybody has their own personality. The way you think about yourself, the way you think about the world, the way you behave, that is peculiar to you. Now, it becomes a disorder if it is causing distress to other people. Anoga amal out there. Any place you are, there is a problem. Do you understand? It could be anything. It could be paranoia. There are some people that they don't have friends. They believe that everybody is against them. They believe that people are jealous of them. They don't talk. You know, it's a paranoid personality. So there are some people that are too quiet. They have no friends. They are cold. They are emotionally cold. Do you understand? So these things are behavioral attributes that at times when they get severe, there is a level of distress, there is impairment in functioning. So to a large extent, so people might have some traits of some form of mental illness, but just like I told you that there is a thin line between normal behavior and abnormal behavior. Normality is a continuum. So but once it's tending towards the opposite end, either positive end or negative end, then the person requires attention. That's why when everybody is saying there's something wrong with this person, or the person is having distress or impairment in functioning. Okay.
Sir, is there any level for people that have too much sexual desire?
All of you here, I hope you didn't sign for people that are not okay. People are saints.
So there is no level.
So what you said, what's the question again?
Is there a level like just like the Nigerians and all this level for people that have too much sexual desire?
Sexual desire. Is it desire or doing it? Which one?
Doing it or
It's part of it now. Compulsive sexual behavior.
okay, that's the
Compulsive sexual behavior. Once you have gotten to a point of affecting your areas of functioning. It's okay, it's the next one.